Welcome to Sage Connections, where wellness meets community. As a pelvic floor and orthopedic physical therapist, I know how important it is to truly understand what's happening inside the body, not just from the outside, but with the help of advanced tools. Imaging can give us that deeper insight, guiding treatment and helping us make the best decisions for recovery and prevention. Today, I'm joined by Dr. Lodewijk van Holsbeeck from Diagnostic and Therapeutic Imaging. We'll be talking about the difference between diagnostic and therapeutic imaging, the most common studies for pelvic floor and musculoskeletal issues, new imaging technologies that could change patient care, and how imaging can be used proactively, not just after an injury. So, whether you're a patient or a provider, this conversation will give you a better understanding of how imaging and PT work together for better outcomes. Enjoy. So, can you share a little bit about your background and the story of your company, Diagnostic and Therapeutic Imaging, which is located in Farmington, Michigan?
Yes, thank you, Luba. So we have been around since November of 2024. Prior to it was my father and my brother-in-law. So my father's name is Marnix with the same last name, Van Holsbeek, and then my brother-in-law is Dan Pipitone, a neuroradiologist, and we are both musculoskeletal radiologists, my father and I. We started, like I said, back in November. Then officially we had the opening in May with a ribbon cutting. Um, and how we formed, I would say, was because of a little bit of built up, what I say this? We were just a little bit frustrated with with the overall system happening in the big hospital systems. Namely, I was up in Saginaw. My father was in Detroit, Henry Ford, and it just seemed like both for us as radiologists, as physicians and radiologists, as well as for our patients that we were treating, it didn't seem like um, we were able to do what we wanted to do, give which is give good care to the patients, efficient and good care without doing harm, which is the oath that we take as medical students.
Yeah, amazing. I will just say that we do have a few patients in common, and I've never heard anyone brave about radiologists before. So it's you guys are, very different than your typical. I mean, we don't really interact with radiologists if we're seeing like an orthopedic doctor. I mean, they're just people who kind of write the report, right? But you guys are so hands-on, which is amazing. So what's the difference between diagnostic and therapeutic imaging?
So I think what most people equate to a radiologist, if they have any idea that that's a physician even, but we are physicians. We've studied ad nauseum. We've studied the physics of imaging, the anatomy, the pathology, and if you do know anything about it, the vast majority of what we do is typically diagnostic, meaning we have patients undergo exams, whether they be X-ray, whether they be CT, MRI, or ultrasound, and then we are at the back end, typically in a darker room, reading images. So by reading images, we mean deducing facts from the images, data from the images, given a patient's demographics and a patient's history and physical exam, we kind of spit out a differential diagnosis or a diagnosis. And then sometimes we also recommend further imaging tests if the imaging test is non-conclusive. So that's about 80%, 80, 90% of what we do is the diagnostic side. And on the therapeutic side, which most people don't realize, we also do image-guided interventions, including a lot of needle placement for, say, steroid injection into a joint or into a tendon. We do breakup of calcium, also typically done with ultrasound guidance. And we can do what's called nerve blocks or temporary nerve releases with different agents that we inject into spaces around nerves. So
Awesome.
a small, much smaller percentage of what we do, but we do both.
Yeah. And it's so important to have the imaging there when you're doing this stuff because you're not going in blind. You're not going in sort of, well, I think it's here. You can pinpoint exactly where symptoms might be
Yes,
coming from. When would
yes.
you need to do calcification breakdowns?
Is typically or classically in the shoulder. It's called calcific tendinosis or tendonitis. But these calcium deposits, they're unsure, as far as I know, they're unsure in the literature why they happen. It's typically thought to be kind of a chronic repetitive trauma injury to the tendon. And they have this calcium buildup, and then the calcium goes through stages, but eventually the calcium tries to break through into an adjacent area, whether it be a bursa or whether into the bone itself. And typically at that stage, patients are very, very symptomatic. And we can take away at least a couple of weeks of pain potentially by breaking up that calcium and trying to suck it out, either breaking it up and or sucking it out of the tendon.
So it kind of presents as what are most people
It,
feeling
it
symptom wise?
it's usually a very localized pain, often attributed to in the shoulder, for example, which is the most common location. Patients typically come with history of, shoulder pain, especially with overhead movement. So it typically does sound like a rotator cuff tendon tear, and that would be the biggest differential in that case.
Yeah. Yeah. What about,
Completely different, they're completely different treatments, obviously.
yeah. So I can see a bunch of different diagnoses sort of getting miss or sort of, I don't know, being attributed to the same symptoms, right? So it could be like frozen shoulder, rotator cuff tendonitis, arthritis, just throwing that as the general umbrella over everything. So
Yeah,
yeah, and that's why imaging is so important because if it's that specific thing and you're treating frozen shoulder, you
right,
could be spinning in circles.
correct.
And I could be seeing somebody as a physical therapist and doing all the things I'm supposed to be doing for frozen shoulder.
Right.
Meanwhile, they need something a little bit more invasive to help with the overall, outcome.
Right, and
So,
we see that a lot. We see a lot of patients here at our center that have really exhausted their options out there, and I'm not talking about um, you know just just that they've been to an imaging center up in the UP that has a no name. I'm talking big centers that these people come from, and they're at a loss. And part of what we do also is kind of to um, to to assure the patient that not all radiologists are the same. You have a wide spectrum of, just like for you, for physical therapists, you have a wide spectrum of radiologists from not so good to great. So
yeah. And that's, that kind of segues into my next kind of topic because the people that we've co-treated, I mean, that's exactly what happened. They went to a bigger place to get diagnosed, and certain things were missed, unfortunately. And the reason why you guys have such, great reviews is because you took the time to actually read the reports. And so I specialize in pelvic floor physical therapy. I do treat ortho as well. But in terms of pelvic floor physical therapy, there's been like a coccydynia epidemic lately. I don't know what's going on, but a lot of tailbone issues. And some of these tailbone issues, it's very difficult to pinpoint. Is it pelvic floor tightness from a muscle perspective? Is it an anatomical, maybe congenital condition where a tailbone might, structurally just be in a certain position that's causing symptoms?
yeah.
Um, and so, are there any other kind of diagnostic tools that you guys use specifically for pelvic floor?
So with regards to what you do with the pelvic floor, first of all, I agree with you in that it is a very difficult anatomical area because there's a lot of structures crisscrossing, from it can be your pain can come from higher up in the pelvis or in the lower abdomen, can come from your hips, can come from a hernia. So I do empathize, sympathize with you on that. But regarding what we do differently or what we can do differently, we are currently at DTI highly focused with ultrasound. And ultrasound is nice because we can see dynamically what's happening. So a lot of these, like even with prolapses, with hernias through the multiple different types of hernia, and with specifically with reference to female, whether it be peripartum around the time of pregnancy, and or after menopause, because of the hormonal imbalances that happen in those time periods, you can have different, laxity of the tendons. You have, in the case of birthing, you have problems with the bones themselves, like the pubic symphysis, diastasis. The pubic symphysis wants to kind of stretch and can sometimes be sprained. So what we do with ultrasound, we can see live, we can see real time uh, things like instability at the pubic symphysis, things like movements of the nerve, non-movements of the nerve, with certain movements of the wrists in the case of carpal tunnel,
Mhm.
et cetera, et cetera. Things that are not possible even with MRI,
Perfect.
which is the biggest, the biggest, I want to say rival to us, but we read MRI as well, but we only have ultrasound currently, and we're looking to expand.
Yeah. No, I mean, it's so there's diagnostic ultrasound in other countries. It's very rare I think, in the US, specifically for pelvic floor dysfunction, but I mean, you can catch hypermobile urethras, you can catch impaction when there's an enlarged sigmoid colon that might be causing constipation, things that you wouldn't think about. When we think about constipation, for example, you're thinking my gut microbiome potentially, impaired motility or something like that. But sometimes that sigmoid colon is just big and it requires more time to kind of fill up in order to evacuate. So, do you guys see that ever?
Speaking about bowel, I do tend to always keep an eye on the bowel because in my prior job, I was doing a lot of abdominal imaging, abdominal and pelvic.
Mhm.
So I'm always looking. I'm always looking. Yes, we can see the bowel. The the two enemies of ultrasound are air and bone. So if it's very gas-filled bowel, then we may have a difficult time seeing. But yes, I'm always looking there.
Very cool. So a lot of people think that imaging is only when something's broken,
Hmm.
but can you share examples of when it can help prevent problems from getting worse?
Sure, sure. Um, so for example, a if we take a snapshot of a case, would be a shoulder patient, midlife, 50s, 60s, with a shoulder pain, and they come for, we say, a more of a screening exam, screening ultrasound of the shoulder. Now, a certain percentage of patients, as they get older, will develop rotator cuff tendon tears, but it's really, you want to get them at a certain stage, because once they're larger than a certain width, and once the muscle starts to atrophy, you can imagine it's much harder and harder for a surgeon to do what they need to do to have a successful outcome. So if we can catch them at an earlier stage, we can potentially save them from catastrophic uh, results in the future with
Yeah.
regards to surgery.
I'm even thinking of Achilles tendon ruptures or when they're not quite at the rupture, but they're
Yes.
not in a safe place to be doing
Yes. Yes.
jumping and basketball and
Right. Right. Yep.
yeah.
And all those people are in a certain category. They're typically, you know, typically middle-aged men. So so you could select those people and kind of watch them a little bit more carefully than the rest of the population potentially.
Hmm. Are there any misconceptions about imaging that you wish patients understood better?
Well, I think we sort of already went over some of that because one of the biggest things I think is that patients don't realize that there's a separate physician behind their report.
Hmm.
So the common misconception, excuse me, is that if you look at these very common series on television, the ER physicians are reading their own studies. The surgeon is reading their own studies. The family medicine, internal medicine is reading their own studies. It's yes, they have to have an idea, but that's not typically how it goes. So we are always kind of the watchdogs. We if we're doing our just duty, we are kind of helping triage patients into either a surgical or medical treatment or no treatment. Leave it alone. It'll get better by itself. So sometimes what we see, if you think about it, a surgeon, for example, reading their own studies, you could quickly see how that could go south in a negative way very quickly because the surgeon typically wants to surgerize. He wants to cut. And so if he sees something that he thinks is a tear, he's much more likely to call it that.
Hmm.
Whereas we are less biased because we don't have a stake in the game, so to speak, in that sense. So we can come at it from a more objective standpoint.
Yeah. And I will say also I have had quite a few patients in the history of me treating that wanted me to read their images. And
Yeah,
I'm always like
yeah,
hands off because I mean we're trained for a lot of things, but reading images, MRIs is not one of them. And there is definitely a skill and an art to it, and you guys go to school for a very, very long time to be able to do this very specific thing.
right.
And diagnostics are so important. We kind of do more of the treatment side, but yeah, it's don't come to your PT with with discs and I mean sometimes it's cool to see for us, and it's very nice that we have a relationship because you can kind of explain things to me that you're seeing on imaging, and that can help guide my treatment. But I would not even come close to being comfortable reading
Yeah,
anything.
at least you're humble enough to say that. Some people wouldn't even say that, you know that?
Ugh, ugh. Yeah, no.
But no, the most important is that we have a relationship, communication, open communication. And so, in the end, I'm not doing this for myself. I didn't go to school for just to, make a name for myself. Yes, I want to make a living, but I want to do right by people. I did that for the patients, and I believe you as well. So, you know, people that just think in inside one box and they don't collaborate, you're never going to get better. You're never going to change the world, little by little. And that's what we hope to do.
Exactly. Yeah, that's why I love talking to all these practitioners we have in our area. We have so many wonderful practitioners, and we all work together, and we all can't do everything. So it's very good to know lots of people, and that's why I love showcasing you because honestly, I've never heard of people raving about their radiologist. So it's so exciting that you guys are in literally walkable distance from my office as well, for all those listening. Um, so couple last questions. So you mentioned that you might be going into some new directions, some interesting new directions. What's on the leading edge of imaging these days?
Um, this question, I don't have a great answer, but I would say that our imaging facility here in Farmington Hills, we have a relatively large building. We only are taking up maybe a half of it at most. So we are looking actively to get clinicians in the building that would help kind of boost us up in more ways than one. And we've thought of multiple different um, avenues for that, whether it be physical therapists like yourself and or other physicians, clinicians on the sports medicine side, orthopedics even, chiropractic. So we have some space to fill, and we'd love to get some more clinicians in here. But in terms of in the short term future, we are looking to collaborate with a pain management physician. So we'll do more of the neurologic work, so like a lot of spine work, spine diagnostic and therapeutics. So
Wonderful.
that's the short-term goal.
Yeah. I mean, it would be amazing to have a one-stop shop where you can get your imaging and everybody's there in one, the village is there and you just walk in and everybody like I mean that's where things get missed, right? When a person sees multiple
Yeah,
clinicians that don't talk to each other.
yeah,
So yeah, comprehensive care is what we all strive
yes,
for,
yes.
right?
And if there's one thing also that I could fit in to tell patients that's very important that I see a problem with almost every patient we see here is that if you've had imaging done somewhere else, you should always get those images and carry them with you if you can,
Thank you. Yeah.
because because we cannot assume, like I cannot assume just from a report that the person reading it saw what I would have seen. So the images are much more important than the reading, but the reading also. So I know what people are saying, why you think you have what you think you have.
Hmm.
And I can go from there.
Yeah. Awesome. So who is the best candidate to come see you and then how can they access you?
That's been a little bit of an issue, specifically with regards to certain insurances. And it's not so much that we don't take them, it's that we are having a really hard time getting reimbursed by certain insurances. So I wouldn't necessarily not come if you don't have the insurance, but we can really pain from any kinds of pain, whether they be attributed to a joint, a tendon, a ligament. Um, the only thing that ultrasound doesn't do is we cannot penetrate through bone, so we cannot see inside the bone. But the vast majority of other things that you could use MRI for, we can do, we can look at. And I would suggest, especially people that, like these people that we've been seeing, people that have exhausted every other avenue, give us a shot because we can find things that other people cannot.
Yeah. And so just to clarify, so you take insurance, but you also accept cash-based.
Yeah,
So in case, yeah, so with insurance, um, so physical therapists in the state of Michigan I did look at, there are some states where physical therapists can actually refer to
yeah,
imaging. Colorado, I think Arizona just got theirs, things like that, but New Jersey, Michigan's not one of them. So if I were to send somebody, it could be a little tricky, but we have lovely physicians in common that I can kind of a
yeah,
route to you through that. But if somebody, chooses not to go the insurance route and would like to come sooner, they can always come and pay cash. And it sounds like you don't need a script for that, right?
right, right. Then they
Yeah.
would just contact us directly, and I'll give you that. I don't know if we
Yeah.
can put it up
Yeah.
somewhere.
We'll put it in the show notes. We'll put your website and all your contact information because I definitely want everyone to have access to you if they need it because it's so important to have good diagnostics, a good radiologist on your team.
Yeah, yeah.
So
And
any
I'm still
last,
learning. I'm still learning as I go as well. So
yeah.
uh, for people who are into, like I want to say this, like name dropping or I would be I don't know if the word is remiss. It would be a very not intelligent of me to not bring up that my dad has been doing this since the year 1990, 1989, 1990. He was one of the first pioneers of musculoskeletal ultrasound. So one of the misconceptions too is that ultrasound is only used for babies. And I've
Hmm.
heard people say that, hey, the last time I had this, I was pregnant. But he kind of saw that potentially. He said, oh, well, could we apply this to the musculoskeletal system? And here we are, decades later. So he's a very well known throughout the world. He's very, very good. And I hope one day to be as good as him. So we're kind of working side by side.
Yeah, it's a family affair over there.
Family owned and family run.
Very nice. Awesome. Well, thank you, Dr. Van Holsbeek. Thank you so much for speaking about the subject, and I think everyone got a lot out of it. And I hope that we will continue working together to help our community and our patients get better faster.
Sounds great. Thank you. Thank you for
Thank
having me.
you. Thank you so much for joining me today. And thank you to Dr. Van Holsbeek for sharing his expertise. I think it's so important for patients to understand that imaging isn't just about finding something that's broken. It's also about getting a clear picture for what's happening in the body so we can guide treatment more effectively. If you'd like to learn more about DTI and the services they offer, please check out the links in the show notes so you can connect with Dr. Van Holsbeek and his team directly. And if you enjoyed today's episode, please take a moment to subscribe, leave a review, and share this conversation with somebody who could benefit from it. Thanks for listening, and I'll see you next time.